I would like us to go on to the second last presentation by Lina Digolo. Lina is a pediatrician with over 10 years work experience in HIV and sexual reproductive clinical and program management. She is currently the care and treatment manager at LVCT Health, a local NGO in Kenya, where she provides oversight for the HIV treatment, gender and gender-based violence, and blood safety programs. So, Lina, you're welcome.
Thank you. Thank you. I'd like to start by thanking the organizers for giving me and giving LVCT this opportunity to come and share the work we've done over the past few years around sexual and gender-based violence, and now currently embarking on IPV. And my task today has been really simplified because we have been all convinced that this is an issue that we should be discussing, and we've seen a lot of data, so my initial slides will be a bit swift. So the outline of my presentation will really be looking at what we know, which was just a run through some data around this issue, and then to discuss briefly on what we do as an organization to curb this problem that we have, and just sharing a few lessons learned and a few recommendations. So this is just that I picked from some of the studies that we had done. This is the VAC study that has been spoken about by previous presenters, but just to briefly refreshen our memories, and we can see there that it is an issue in the region, with most of the study participants in this study being who underwent violence, went through it before they were 18 years of age, and a big number, I mean, across all the countries there, you can see a third were actually the women who are, let me call them girls, the girls who are studied here, about a third of them had experienced violence. Again, this slide was just to show the relationship between violence against children and violence against women. This has been emphasized by previous presenters, and I think for me, my point of emphasis is we can't delink these two issues. This study actually found that women who had undergone, who were undergoing IPV had when they compared those who had undergone, who were undergoing IPV, when they compared women who had IPV, the larger number of women who, sorry, I think I'm lost there. Basically, I think the results of this study showed that women who were undergoing IPV were more likely to have undergone sexual violence when they were much younger, and that has been emphasized. This is a recent study that was released and done in Asia Pacific, and this was to emphasize again risk factors. They looked at men and wanted to see what were the risk factors that really led to perpetration, and you can see in green there, highlight there, child abuse, emotional, physical, sexual, contributed greatly to those who perpetrated later on. Tanzania showed us results showing the relationship between sexual violence and HIV. I'll not go through this because this has been emphasized by other presenters, but just really to emphasize from our VAC study in Kenya, and I think all the other VAC studies in Tanzania and the other African countries that have completed the study showed that most of the survivors of violence do not have access, are not accessing. One, because they are not aware that the services are there, but also because they don't think they need to access the services. This was similar in Kenya, and you can see both boys and girls were not accessing the services. So we can't continue ignoring this data. One, there's a high level of sexual and gender-based violence in Women, we are not saying men are not undergoing it, but it's really a big problem in women. We can't delink. We should be talking both about violence against children as we speak about violence against women, and program around these two issues together. There's an interconnection between the sexual violence and HIV. Again, we can't speak about those two in silo. And majority, just to remember that majority of these people have no access to services. So quickly going through what we do as an organization. It's a local organization in Kenya. And those who don't know Kenya, it's a beautiful country. You feel free to visit. We have currently about 38 million people. And prevalence of HIV with our last KDHS was still quite high, coming down, but some regions still had it quite high. And that's the same with the prevalence of violence against women, which I think we've had today. Our last KDHS found that this prevalence was about 47%. So LVCT, our programming is, we program under 3 pillars. One, we generate evidence. And so what we do is run studies, mostly operations research, and use these studies to inform policy. So our biggest partner is the government. And once we inform policy, then we use we also go back to them and see how to bring this evidence that we generated to scale. So to date, we've done about 28 operational research, and out of this, 10 have formed tangible policy reforms within the country. So I'll just zoom into the post-rape care program, which we started in 2001. Our first study that we did was based on a question that the country kept asking, is this even an issue? And if sexual violence is an issue, then when you go to the government and say you need to program around this, they'll ask, what's the issue? Or the intervention that you're recommending, does it even work? They're not going to invest on things that they don't understand. So we did an operational research which really informed, which looked at a model that was feasible and acceptable and could be scaled up by the government. And this study actually led to the first national guidelines, informed the national training curriculum and development of what we call the P3 form, which is the form that's data collection form that's used at the healthcare facilities. Next, we were asked, so how much does it cost? Because this was run at 3 sites that were controlled sites. And so we went ahead and did a costing study that was able to estimate what it would cost per person for the government to bring up this program. And this led to the scale up of the PRC program. And now we have quite a large number of government facilities providing this program. Within LVCT, we scaled up technical assistance from 3 to 130 sites, but I know we are in more than those sites because we are not the only implementing partner. So, of course, with scale up then comes issues of quality, and now you start looking, are we actually giving comprehensive services, and what is a comprehensive service anyway? So questions about services within the healthcare facility being strengthened, but also recognizing that sexual violence is not a health sector issue, but a multi-sectoral issue. We then took up a study to look at how do we even link this patient from one site to another, but also to test a model to test the movement of the evidence from health facility to the justice system. And this was done together with Population Council and other partners. And it actually informed the development of our medical legal cross-sectoral standard operating procedures, which for us, I think it's a plus within the region because just reviewing other policies and policy documents, it's something that is not quite common in Africa yet. So we do have a policy around how different sectors work in terms of giving comprehensive service to the survivor of violence. And currently we're working together with GEC is our National Gender Equality Commission, which is constitutionally mandated to coordinate activities across the sectors and especially across gender and gender-based violence issues to develop a gender monitoring and evaluation framework which will ensure that we are able to collect data across the sectors and not necessarily per sector. So we'll be able to soon see how we are managing our survivors from healthcare to justice, which we've never been able to do before. So that's just a flow of how we've grown in terms of building the post-rape care program. And this has been effort from not only LVCT, but many other implementing partners and key working together with the government who've been very supportive in terms of being members from the study team to policy development and even enabling us to scale up our study findings. So currently we are running a study, a 3-phase study on intimate partner violence. We completed the phase 1 of the study, which just a build on to what Population Council did, but for us we were testing feasibility of screening in community settings, which is a bit different because their study was in clinical settings. And we did this in our HIV testing and prevention sites, and really to see whether it was even acceptable or feasible to both healthcare providers and to the women who are attending these services. And the results were quite impressive in terms of acceptability. Acceptance was more than 90% in these women. And we found a quite, almost similar to what the national prevalence showed, about 47% of them screened positive. Of note is that during the study, we referred anyone we found positive to to psychosocial services, but on getting feedback from the participants who actually took up, referral uptake was low, 29%, because it was not active. It's just give a letter and tell them to go. But also, only of those who went, only 24% were happy with the services they received. They actually did not feel that they gained from those services. So our next phase of the study, which is about to start, is we're going to be testing an intervention where we strengthened the screening tool that we had. And this time it's not only going to be screening for risk of IPV, it will also be testing for severity and chronicity for those we find positive, but also we've developed a facility-based intervention which is more of an enhanced counseling intervention that we hope to see reduce the risk factors, or the risk to IPV for those who have experienced and also those who haven't experienced but at a high risk of IPV. In the 3rd phase, then we hope to use a community to combine the facility intervention with the already existing. We'll probably adapt one of the existing good community interventions that we are now hearing and see the effect of bringing both facility and community-based interventions in terms of reducing the intimate partner violence. We'll be sharing the results. So just some key results that we have from our programming is that to date we've seen over 20,000 survivors. And we do this using 2 models, the integrated PRC model, where these services are given within the public health setting in the outpatient department, but also we have standalone 4 gender-based recovery centers, which we use as referral centers, which are highly specialized just for gender-based violence. We are now currently at 130, sorry, that needs to be updated, health facilities. But we've also trained providers to provide these services. And these are not only healthcare providers, but also police, justice system, and other non-medical, but community-based healthcare providers. We also work together with other countries to strengthen their programming. We've worked with Botswana, we've worked with Malawi and Ethiopia, and we've supported them to sort of use similar models, but obviously adapted to their context in terms of GBV programming. Those are just some of the standard tools that we've worked with the government to develop for these services. So what we've learned is very simple. We've learned that for this programming to succeed, you need strong leadership, and the leadership must come from the government. And so they must be engaged in any intervention from the beginning to the implementation to the evaluation for it to be successful, and so that any evidence that you produce can be brought to scale in future. Our biggest gap probably regionally is that we have very good interventions, but they remain within the project, but these need to be scaled up. So we also have to be cognizant of our local realities, and that means we need to generate our own evidence. Most of the evidence we work with are probably from the West, or works in a different country, but if you contextualize it to the region where you are, then it's probably not applicable. But that doesn't mean that we go developing new interventions. You could borrow but adapt it to fit your local reality. That speaks to the third thing, that you need to build evidence before scaling up. So another key thing is monitoring evaluation, which many of our projects seem to forget. You need a strong, it doesn't have to be research, but rigorous monitoring and evaluation of all these programs, and definitely looking for resources to fund the project. What we recommend is that we need to interlink our programming. In our PRC program, or let me call it our GBV program, 60% of the survivors are children, and these are the people who will go and grow up and start experiencing either intimate partner violence or become perpetrators, as data has shown. And we need to train our providers. One of the studies we did, or actually a number of the studies we did, part of the reasons given by providers why they can't provide these services or why the services are not of quality is because they don't know how to. So capacity building is still an issue. We need to leverage on current programs that are mature, like HIV. HIV has gone through this whole process, and what we need to do is really probably train the service providers within our clinical settings, CCCs, and let them be able to provide these services, but also learn through them, learn through the processes that they went through as a program, and build onto our GBV programming. We need to invest in local research and use this evidence to inform policy and to bring the evidence to scale. Thank you.
Thank you very much, Lina. Thank you, and apologies that you had to go through the presentations very fast, but I think you did a very good job. And she again calls us to make the interconnection between GBV and
Good afternoon,
and VAC.
and thanks for allowing.
Okay, I think her presentation also is a good piece on from evidence to policy and practice, and also the issue of how do you cost it? You know, what is it going to cost? And I think a lot of times this is the question. We do all the science, we do all the evidence, and they just give us one question: how much is it going to cost the Ministry of Finance? And that ends the conversation. So thank you also for moving the conversation to that level.